Welcome. I'm Michelle Cowles, Director of Business Development with Rogers Behavioral Health. I am the moderator of today's webinar. Joining me today is Dr. Brett Johnson, a child and adolescent psychiatrist based at Rogers San Diego location, and Dr. Stacy Welch, Clinic Director at our new Seattle location, which opened on March 8th. Before we get started, I just want to give a quick overview of the format. The webinar is scheduled for 90 minutes. There is no need to check in. To receive CE credits, you must be logged into the webinar for the entire program. A PDF of the PowerPoint slides and a list of references will be available after the program via email sent from ce-go.com. In addition, a recording of the webinar will be published on resources section of our website within the next few days for you to rewatch. Our presenters will give a 70 to 75-minute presentation. Following their presentation, I will facilitate the Q&A session. If you would like to ask our presenters a question during the presentation, please use the Q&A button, not the chat button, to send me a message. At the bottom of your screen, you simply click the Q&A button on the Zoom taskbar. I will review the questions submitted, then the presenters will address them during the Q&A portion of the webinar. We do have a lot of participants in this webinar. If we don't get to your question, you can send me an email and I can ask our presenters to answer later. And now I will turn it over to Dr. Welch and Dr. Johnson.
Hello, thank you so much for being here with us today. Dr. Johnson and I wanted to start out by letting you know we have no financial relationship in any way. We have nothing to disclose. We wish we did, but we do not have any financial benefit to any of the information we will share with you today. All right, let's go over the learning objectives. Today, we hope that by the end of this program, you'll be able to summarize at least 2 risk factors that are common to both generalized anxiety disorder and major depressive disorder that we'll be talking about today. We hope participants will be able to identify at least 2 psychopharmacological strategies that can be used to help patients with co-occurring GAD and MDD. And we'll describe 2 ways to incorporate elements of exposure and behavioral activation treatment strategically to help clients with co-occurring GAD and MDD. So to those learning objectives, what we'll cover in this webinar, first are some common elements and challenges that really show up so frequently with patients who have co-occurring anxiety and depression. And we'll review just a little bit about the literature in this area that's really interesting, but keep an eye towards what might be really helpful to you clinically. Dr. Johnson will then talk about using medicines to support the therapeutic targets that patients have. And then we'll talk a little bit more about ways that we've learned at Rogers to weave exposure treatments and behavioral activation treatments together to really help these patients with co-occurring disorders. And those treatments, exposure and behavior activation, or BA, are not the only ways to treat anxiety and depression, but those are ones that are relatively simple and brief, have a lot of evidence to support them. And so those are strategies that we heavily utilize here at Rogers Behavioral Health. All right, so let's dive right in to some common elements and challenges that those of you treating a lot of anxiety and depression will recognize, I think, very quickly. So this topic is a really interesting one to be talking about now during the pandemic. Since the pandemic began, we know that rates of anxiety and depression have not only increased, they've quadrupled. And we see that burden disproportionately borne by women and people of color. You can look at, and it's really interesting to see some of those statistics right on the CDC website, cdc.gov, and you'll see what I'm talking about. Even before all this, depression and anxiety rates co-occur, GAD and MDD co-occur so frequently that you'll often see the rate cited at 60%. And it's so high, that co-occurrence, that some of you may remember in the transition from DSM-4 to DSM-5, there was even a lot of discussion about, hey, are these actually two separate disorders? Or could they actually be the same thing if they co-occur at this high of a rate? And that's a really interesting thing to think about. Those of you on the front lines, clinicians, you already know this. We're not telling you anything that you don't see every day. One thing that is so, it's just sort of mind-blowing, the statistic. Here's one, just to tell you what you already know. If we applied some of the commonly applied exclusion criteria to our practice, our kind of real-world practice for anxiety disorders, as an example, we might actually leave out up to 92% of the patients who actually seek treatment in our offices. So, comorbidity is the rule. Co-occurring disorders are the rule, especially with GAD and MDD. And it's not irrelevant, it really matters. So we know that it can actually cut the rate of response to treatment by up to half. And so even though this is these are sort of these rules of clinical practice, our treatments, if we're looking towards the evidence-based treatment movement, which a lot of us are subscribed to and practice in settings where that's a real emphasis, those treatments as they're studied tend to be pretty monofocused. So you can go in ready to do your evidence-based treatment and find, wow, I might need a treatment for social anxiety and GAD and MDD and panic. And how do I use like 6 treatments with one patient and they want to work on everything at once? So with GAD and MDD specifically, there are a lot of overlaps, and one that really stands out is just this pervasive and dysregulated negative affect. And you see that in adults and kids. And I should say, Dr. Johnson, jump in at any time. Those participating in the webinar will soon find we're both talkers, so please jump in if you want. One area that given that these disorders are, they're sometimes called the distress disorders, one thing I really started to ask myself when I was encountering this co-occurrence as a clinician is, well, what's the difference between depressive rumination and anxious worry? Because in both cases, people are thinking a lot about their distress and their symptoms and why it's happened and what's going to happen. This is a guide that we often use that I've found really helpful. That's a difference and a way to kind of categorize these common problems. Where depressive rumination, we talk to patients about the way that this kind of focuses more on the past, frequently on this firm sense of a negative past and a negative future. And you really see themes of grief, of sadness, hopelessness, and loss emerge as very central in that depressive rumination. Anxious worry can look and be very similar, but if we're going to parse it out, we tend to look at that more as focusing on the future, the what ifs. And often you find that the anxious worry has a little more of a somatic or physical component, themes of fear or threat. Sometimes you don't know which is which till you get into treatment, and that's okay. I will never forget supervising on a large study in primary care. We were doing treatments for anxiety and depression, and we had a patient who was doing some exposure for his worry. We'll talk about what that looks like a little later in the webinar, but he was talking with the clinician about his worry that if he got hurt on a job site, he was in construction, he would lose his source of income and not be able to care for his family. And that was what he worried about. And as he talked about it with the clinician, I'll never forget listening to the tape. I was supervising and he broke down and began to sob. And the grief of not only his situation, but all the prior generations of his family who had come from extreme poverty. They were refugees. And he was so sad. And we thought, gosh, that's going to be a little bit better fit with some of our depression interventions. And we didn't know till we got there, and that's okay. Another question you might ask as a clinician, and this is one that's really interesting, but I find it also relevant in my day-to-day practice, is how does this happen? Is it that someone who has a predisposition to worry and maybe worries a lot as a teenager starts to avoid things in life? Maybe they're not going to go to the dance or apply for the job or take that test. Maybe because of their avoidance, they have lives that are more depressing, and that's why they develop MDD. Maybe it's that. Or maybe it's that they get depressed first and then have a life where there's a lot of avoidance. You know, if you stay in bed all day and don't get out, you might end up with a life that makes you worry a lot because things aren't going that well. Maybe it's that pathway. Or maybe it's this genetic contributor that we know a lot of these patients share towards a negative affectivity, kind of this genetic tendency to really feel the hard stuff in life, anxiety, sadness, pain. So that's an interesting question. Like, is it chicken or the egg, and what do you look at first? And what we know from the literature is that all three of those pathways are actually correct. And it falls, as many things in mental health science do, about in a rule of thirds. So each of these pathways is a way that your patients may come to the experience of having both GAD and MDD. And that's really helpful. You know, how do you know which it is? Of course, our big technique as clinical scientists is to ask our patients and really listen to the development. And that can be very useful to you as you're setting up treatment and helping patients understand what's going on. We have, luckily, good treatments for both anxiety and depression. I have a little star there because as my mentor in graduate school used to say, Marcia Linehan, she used to say, you know, what we have is the best we have, and it's not good enough. And that's sort of how I see the state of the science with GAD and MDD. We have good treatments, they work pretty well, but we don't get the kind of studying outcomes that we would get for a specific phobia or panic disorder. We're getting a good percentage, good 50% of people are benefiting, but you know, hopefully in the next 10 years, we'll have better treatments. CBT, cognitive behavior therapy, is one of the well-established treatments, and that's the frame that we tend to use here at Rogers. Many of you have some training in. And under that CBT umbrella, there are really two specific interventions that, you know, again, in our setting, we really rely heavily on them. They're not the only way, but they are a really useful way. And one is behavior activation, which is a standalone treatment for depression, where we basically help depressed patients activate, do things that are going to be healthy and more enjoyable for them. And then we try to help our anxious patients expose themselves, use exposure therapy to things that they would have feared and avoided, and try to help them get around things that they might be very afraid of, but actually aren't dangerous enough for that anxiety to start to go down, or for them to have the experience that they can handle it and have their confidence increase. One thing that's cool about the literature on GAD and MDD is that when we look at themes that are helpful for patients, some of the stuff that we do in CBT really comes out. So one study, if you're interested in this literature, that's really fascinating to read, is this site is on the slide. It was a longitudinal study, over 3,000 patients, and they were assessed 3 times 9 years apart. Really cool data set. And they asked the question, what is it that people do who tend to not have these persistent co-occurring disorders over time? What do they not do? And if you take a big step back, the big thing that helps people is goal persistence. Locking in on that goal, not giving up no matter what, that variable tends to help people a lot. More than like self-mastery, which really surprised me when I saw that. But wow, that's so interesting and useful in practice. Positive reappraisal also really helps. That kind of ability to look at for the good in even the hardest of situations. Kind of Gandalf method, as one of my teen clients likes to say. Um, but in clinical practice, when we're trying to get towards, activation, exposure, goal persistence, the co-occurrence often gets in the way. And here's some ways we see commonly get in the way. And then we'll jump into some ideas that Dr. Johnson and I find are really helpful in our own work with patients. The first thing is that when you jump in and start to work on behavioral activation, go out and take the walk, take the shower, call your friend, go to the library. Patients who start to work on that for their depression often become very fearful and anxious, and then quickly will want to switch goals or give up on that behavioral activation goal. Another common problem is that patients who begin exposure therapy for their anxiety are often so depressed, it's hard for them to motivate. It's a very hard therapy to do. You're asking people to face their worst fears again and again and track them. It takes a lot of energy to do that therapy, and depression can really make it harder to do that. I have found, in our system, we're really trying to tackle a lot of things at once because we do work in Seattle in a partial hospitalization program. So we're really trying to tackle anxiety and depression at the same time. And what I find is that patients often get really confused between the distinction between an activation hierarchy and an exposure hierarchy. And it may make sense to those of us who are really used to these treatments and the jargon and what we're doing. It makes a lot of sense, but for the patient, it's sort of like, what is what? Because these things all feel fused together in the experience of a really hard, difficult, and scary life. So those are some of the problems. So what do we do about this? So I wish that I had a beautiful data set with a lot of randomized controlled trials to show you and tell you exactly what to do. And hopefully in 10 to 20 years, we will have that. But for now, Dr. Johnson and I were joking, it's the expert tips. And then we realized we were the experts. And we thought, oh no, but we're going to offer you some of what we have found useful in the hopes that it's a helpful offering to you. So a lot of these, as I thought about this topic and thought about my own clinical experience and my view of the scientific literature, what really comes to me is that stepping back and thinking about the frame, both for myself as a clinician and to make sure my patient knows the frame, is incredibly helpful. Let me tell you what I mean. Let's actually use a client example. So if y'all read with me the story of Adrian, is a 35-year-old non-binary Latinx individual. They experienced early childhood abuse leading to placement within the foster care system. Adrian was one of the few non-white students in their school, got a lot of teasing, a lot of rejection, were very socially anxious, never dated, didn't have many friends, and eventually dropped out of school. Got a GAD, had a lot of success in their career as an electrician, but were laid off in the pandemic and have really struggled financially. And Adrian came to treatment with depressed mood, anxiety about the future, low social support. Of course, names have been changed to protect confidentiality. And this is just a typical case. Primary worries were about, I'm never gonna have a relationship. I'm never gonna be able to support myself. I'm in bed all day. I don't even want to face the day, very isolated, feel like I don't have good social skills. I'm going to be alone forever and worried all the time. And this is the presentation that's not uncommon. So traditional CBT models, we're going to go in and we're going to have a depression treatment and an anxiety treatment. And it might look something like this. We might talk to Adrian. Those of you who know BA really well, forgive the overview. I wanted to do a brief intro for those clinicians who maybe don't do BA as much in their practices. We would give a rationale speeding through that looks something like this. We'd talk to Adrian about the triggers that they experienced, being laid off, for example, a really normative emotional response of sadness and worry, and then a pattern of avoidance, which of course we see in depression, where people really kind of drop out and avoid the things that are painful. And it makes sense We're wired to avoid pain, but then that avoidance tends to lead to a real ongoing cycle where everything that was really hard and depressing is now even more hard and depressing, and it goes in a vicious cycle. So in behavior activation, that's the trap. We try to use this track idea. This is a slide from my colleague, Dr. Rachel Leonard, and comes from the work of Dr. Christopher Martel and Sona Demidzian and others, where they talk about the track model, where we'd say, Adrian, we want to, instead of having these triggers that you respond to with staying in bed all day, we want to really engage you in active coping. And that, even though you don't feel like getting out of bed, that getting out of bed is going to help to stop this cycle of depression. That's kind of what BA might look like in a nutshell. Now, Adrian's also really anxious and meets criteria for GAD. And we might use, this is a model for treating generalized anxiety that we really like here at Rogers. Again, it's not the only way, but it is a tool. The work of Dugas is a real wonderful book on treating generalized anxiety disorder. And this is a slide from our colleague. I believe this is Dr. David Jacoby's slide. We might present a model of uncertainty, that novelty, ambiguity, unpredictability can really lead to a very uncomfortable experience of uncertainty. Sometimes we think of people with a tendency to worry a lot as almost having like a little uncertainty allergy, where some of us we don't like that feeling. We want certainty. All of us do, but maybe some even more than others. And in the effort to, me and Dr. Johnson would probably be on that list, huh? There's this effort to try to control, and worrying about things, trying to find the solution is one way to try to get control. And so we might start to teach Adrian about tolerating uncertainty, and we might build an uncertainty hierarchy. So these are great treatments, and this is a lot. This is a lot for a new client. So one thing that we find, and I'll just kind of introduce this frame to you, and then I'll turn it over to Dr. Johnson, and we'll come back again to this frame towards the end. One thing that's really important I've found to do is to streamline and simplify with goals. Always looking to goals to frame these treatments. So taking some extra time with a client with co-occurring MDD and GAD in the beginning to really understand their goals and perspective before launching in with psychoed or intervention will take you more time initially. It might take you that extra day in programming or that extra week in outpatient treatment, but trust me, it will save you and the client so much time and effort in the long run. I know that's difficult in a lot of systems, and take some creative problem solving. But if you can start with the client's goals for their life, not just treatment goals, you will have a frame that really helps. A tip, when you ask someone with GAD and MDD, what are your treatment goals? They will almost always say, I want to worry less and feel better. And then you have the dilemma of saying, cool, now I'm going to give you a treatment where I have you go worry on purpose or do things that make you worry on purpose. And I actually want you to tolerate being anxious. And I want you to do stuff even though you feel depressed. And you're already in the weeds before you've really gotten very far. So a really helpful tip, I know it sounds simple, but it really has helped us so much, is to start with their goals for their life. What do you really want big picture? That's our job description as therapists. We're working for those goals. And so not just treatment goals. Ask about treatment goals second, but really get that big picture. Some clients have trouble identifying their goals. Just going to take a minute or two at most here, Dr. Johnson, and then I'll turn it over to you. It's hard when they're overwhelmed and have a hard time persisting with goals. So don't panic if your clients are like, I have no idea. That's a very common presentation. Remember that a lot of these clients have never had a peaceful or happy life. So that's part of our job, is to help them begin to envision what that looks like and streamline our treatments, everything towards that goal. So sometimes starting with what they don't want is fine. You don't want a life like this. Okay, would a life like this look better? Remember, as the clinician, you have someone in your office or in your setting who has trouble seeing a positive future and believing they can get it by definition. So part of your goal as you're getting goals is to model goal persistence. So you want to be sort of relentlessly optimistic about finding that goal as a stance. And that will really help you be patient with yourself and your patients. Value sorts are something we really like to use in our treatments, vision statements. Positive psychology blogs are great for this goals question. You can go take inventories of your strengths and, asking teens, one of my favorites is like, go watch TV, which most of them are doing anyway, or YouTube now, and tell me what life do you like? What character has a life you don't like? Things like that, really getting creative. If clients have trouble identifying treatment goals, that's also very common. Clients who say, well, I want to have friends and, a job, but I don't know what I want in treatment. That's great. There you can start to educate about activation and exposure. And a great plan is one that you're working for, let's say, getting a life with friends. And then the treatment targets might be calling someone or texting someone and tolerating the anxiety that comes up in doing that. Stuff like that can really help you streamline. Using the common factors, I would guess that almost everyone in this webinar went into this field because they have a lot of natural empathy and want to help people. And we know from the literature that even in addition to the interventions that we have, these wonderful behavioral technologies, common factors matter a lot in the success of psychotherapy. So just doing things that normalize the experience that having GAD and MDD is really hard. It's hard to be down and worried. Generating hope, letting people know that it is very hard, but people do recover. Helping your client imagine not just the perfect life, but remember what we want, that goal persistence. Imagine them feeling negative emotion and having the power to persevere till they get the life that they want, taking time to get buy-in. These are all very obvious. I know I'm telling you things but often with these very challenging presentations, it's easy to feel kind of quickly demoralized and incompetent as a clinician. And so just taking that step back for that frame is a good idea. And I'm gonna just stop there. So I'm going to stop sharing my screen and we'll pause here and think a little bit about medicine. So I'm going to turn it over to Dr. Johnson.
All right, let's see how good my tech skills are. Let's see how it goes, right? By the way, Dr. Welch, I have known you for a couple of years now. I have never given a presentation with you before. Remind me next time to go first because you are a hard act to follow.
Stop it.
Uh-oh, that's avoidance. Uh-oh. Design my own exposure.
I'm not going to reassure you right now, although you're going to get comments reassuring you.
Well, thanks so much for that. That is an excellent overview. And I think that one of the things that people can say about the treatments, whether it's behavioral activation or CBT or ERP exposure therapy that we do, I've had a lot of friends tell me, that sounds really boring. And I actually find it some of the most creative out there because for the reasons that you said, it has to be individualized as well. So thank you so much for that. So if therapy is great, which it is, why are we here? Why are we talking about medications to support these therapeutic targets? If I had to choose one or the other, with these conditions, it would hands down be therapy. Now, obviously, I'm a psychiatrist, so I clearly believe there's some utility. So let's go over that as well. So why would we consider pharmacotherapy? First up, just to loop back to what Dr. Welch was saying, if the degree of symptoms are so incredibly severe, if someone is so incredibly depressed that they're not going to be able to, effectively engage in therapy, they don't have the energy to get out of bed, sometimes pharmacotherapy can be a useful adjunct to that. Also, you may have a partial response to therapy. But I, I am going to mangle Dr. Welch's quote of, yeah, this is good and we can do better, right? And we deserve better, our patients deserve better. So how do we get them across the proverbial finish line? Oh, by the way, that is in Philly. Rogers has a clinic there in case we have any East Coasters here. So we don't want to just say that we're West Coast in Seattle and San Diego.
Oh, Dr. Johnson, I noticed you're not in presentation view.
I'm sorry?
You're not in presentation view, so it's showing like your slides are showing double on the screen.
Ah, thank you. I told you I would fail on the.
I don't call this a failure.
So Okay, did that fix it? Please say yes. Just lie to me.
Yes. Yes.
Okay, there we go. The hazard of being an old dog and new tricks and using Teams all the time and not Zoom. So thank you so much for that. Let me back up here. So I come from a more rural part of the country. So it is hard enough in larger metropolitan areas, such as Seattle, such as San Diego, to find really high quality, evidence-based therapy. So there are huge swaths of the country where this simply may not be possible, or because of insurance restrictions, it may be hard to do. So it doesn't necessarily feel the best to say, okay, I don't have this option, and meds can sometimes be better than nothing. The final one is of course, patient preference. What are their goals? Some people may not be ready to engage in therapy, or their lives may be so filled, they might be so stressed that this is just not the right time. So in that case, that would be another thing that may switch us over into and consider pharmacotherapy. I am not a neuroscientist, and I will try to go through these quickly because I do not want you falling asleep because Dr. Welch has some other exciting stuff to talk about after me. So this is what's called a sagittal section of the brain. So if you imagine a slice directly through the middle of your brain, and then this is the side. So the point of this slide is, if you look at the very bottom words on the slide where it says raphe nuclei, these are parts of the primitive parts of our brain, pons and brainstem and all of these great things that keep us alive. This is where all of the serotonin in our brain comes from. Just a couple of little bitty blobs in the brain. Blobs is a technical term, by the way. So if you notice, even though they only come from a couple of small areas, these go all over the brain. So if we go, that would be clockwise. So if we look at the temporal lobe, so we're talking about emotions and memory, obviously things that can be thrown out of whack in both depression and anxiety. Above that, hypothalamus, we know that appetite, that controls appetite and eating and all kinds of very basic physiologic functions. We also know that in depression and anxiety, we can see disturbances in that as well. Frontal lobe, so in terms of executive functioning, planning, concentration, sometimes, if someone's depression is so severe, there may be a concern that they actually have a cognitive impairment. It can look that bad. Basal ganglia, and in terms of movement, so that profound anergia, that difficulty, physically getting moving. Also the cerebellum at the very end there, also involved in movements. And finally, the thalamus. The thalamus basically does everything in the brain. It's like a relay station. So if some very smart neuroscientist could actually explain what the thalamus does, I would greatly appreciate it, because it is involved in everything and understood very little. So let's turn now to norepinephrine. So on this one, if we go to near the bottom of the, on the left side of the screen, where it says locus ceruleus and the lateral tegmental norepinephrine cell system, which just rolls off the tongue, by the way. I love naming these, right? Those are the places where all of the norepinephrine in our brain comes from. Now, if you look at where all these projections, where it goes to, it's gonna look similar, right? So we've got the amygdala, so involved in many things, but fear response very closely attached in terms of memory consolidation, because if something is really scary, you're gonna want to remember it. So that's why it's right there, you know, near the temporal lobe. Frontal lobe as well, in terms of being able to pay attention, focus, concentrate. This is why we think that boosting norepinephrine may help with concentration and focus in patients who struggle with ADHD and related disorders. You know, for the sake of time, I'll leave off the rest here. But you get the idea that what we're seeing here are two very important neurotransmitters that go to parts of the brain that are we see clinically. We know that something is wrong, something is perturbed in the system, the circuit, something, because you know, with all of the symptoms that we're seeing, appetite and sleep and all of those basic things, and drive and happiness and all of those clearly disturbed in depression and anxiety. Okay, so neuroscience lesson over. So hopefully if you have some caffeine, you can wake up there. This is some tea there. So that's the basics of it. But what do we do? What do we do with all of this information? So the good news is that we live in a very fruitful era in terms of medications and medications and medications and medications and medications. These are almost all of the medicines that you know are FDA approved for depression. Some of them have anxiety indications. And what the heck are we supposed to do with this mess? So what we do is, thankfully, so the bad news is, well, I guess the good and the bad news is that there are tons of choices. The good news is that we can really whittle this down for most cases. So the most commonly used medications, so if we look at the yellow circle there, are the SSRIs, so selective serotonin reuptake inhibitors, medicines that boost serotonin throughout the brain by inhibiting the reuptake of the medication. There's a typo in the what is that, teal maybe? Teal part of the slide. It should say SNRIs, so serotonin norepinephrine reuptake inhibitors. These are SSRIs on steroids. So they do the same function in terms of increasing levels of serotonin? Yes. And they also work on norepinephrine as well. So if we break these down, these are some of the most commonly used medications. I was going to say in psychiatry, but actually, just across the board in general. So some of the most common SSRIs, fluoxetine, sertraline, citalopram. One that's on the list there, fluvoxamine, is technically FDA approved for OCD only. However, basically, all of these work, they keep trying to do studies to figure out, hey, maybe my medicine will work better than your medicine. They're all a wash. They all, the response rates are approximately the same. For SNRIs, we only have a few of them. So venlafaxine, a fancy version called desvenlafaxine, and then one called duloxetine as well. And then the FDA approvals are there. I am supposed to mention any off-label use of the medication, and I just did one for fluvoxamine, only FDA approved for OCD, although wink, wink, we all use it for other conditions as well. Now, there are a whole host of other agents that I'm not going to belabor, but there can definitely be reasons why we might move in a different direction. So if you look at on combination agents, mirtazapine, it can be useful if someone has profound difficulty with sleeping. It can also be used to stimulate the appetite. Further down on the list, there's bupropion and budeprion. That if someone has really profound anergia with their depression, then that can be a little bit more activating to get them going. The tricyclic antidepressants are used much less commonly now, and that is not because they don't work. They work just as well. Surprise, surprise, they work just as well as all the other antidepressants. But the side effect burden is much greater, and also the potential for lethality in overdose is great. Not saying that SSRIs and SNRIs are 100% safe in overdose, but they are many, many, many times safer than tricyclic antidepressants, which can cause seizures and abnormal heart rhythm and death. Especially concerning if you're treating someone with depression who may have suicidal thoughts. And then finally, the oldies but goodies, monoamine oxidase inhibitors, very, very rarely used because of because of medication, food interactions, and also side effect burden. They can be sort of one of our Hail Mary approaches when other antidepressants don't work or are poorly tolerated. So in the couple of minutes that I have left here, I want to say a few words about anxiolytics and hypnotics. So even though SSRIs and SNRIs can have a very robust benefit in terms of treating anxiety, sometimes they just don't get us across the finish line, to repeat that metaphor. So some options that are available include the benzodiazepines. So these would be, there's a whole list of them. I didn't fit them on there. Alprazolam, diazepam, clonazepam, anything, a PAM, it's a benzo. So, so those medicines work very, very quickly. SNRIs, SSRIs take several weeks to work. The dosage for anxiety is really typically quite high. Takes a while to get there, and then it takes several weeks to begin to kick in. So these meds have the benefit of working faster. Just for the sake of time, I'm just going to say a couple of words about the hypnotics. The data are clear that if we do not get a patient's sleep back on track, their chance of their depression going into remission is greatly reduced. There's just one problem, that typically sleep is one of the last things to improve with pharmacotherapy for depression. So sometimes a bridge of a hypnotic, trazodone, off-label, everyone uses it. It's a very sedating antidepressant. At low doses, it has no antidepressant properties. Also off-label antihistamines, Benadryl, Vistaril, those things. The group of meds called the Z drugs, so this would be zolpidem, zaleplon, and azopiclone. Woo, mouthful. I want a job naming these meds. And then tricyclics and melatonin can also be used. So if you want to amuse yourself and you're in a room with a lot of psychiatrists, just throw out, I don't care if you make a pro or an anti statement about benzos. And then just sit back and watch, because it will be fun, because it will be a battle. This is one of the most controversial things in my line of work. And you can find data and supporters on any side you want. So what are the pros of using benzos? Benzos are very effective and they work very, very quickly. So sometimes we will use them as a bridge because the other meds take weeks to kick in. Also, if someone comes to you in great distress and you say, you know what, we hear you and we're definitely going to work with you. This is a temporary medicine that will help you feel better until we can get the other medicine to work, until we can get the therapy to take hold. The cons are that they can be sedating. There is a potential for misuse. There is a potential for overdose. They are much safer than older medicines that we used to use as sedatives, but particularly dangerous when combined with alcohol. increased risk of falls, especially in older persons. And once you get started on it, and the person feels so much better with their anxiety, trying to convince them to come off of it can be a very hard sell. And then finally, it's a controlled medicine, so refills on it are limited. There are certainly some benzodiazepine alternatives. So buspirone, Buspar being the most common, gabapentin is sometimes used as well. But for the sake of time, we're going to move on here. So this is where I would actually like to leave off. The other ones show treatment algorithms and can walk you step by step, but those are on the slides, and I'm not going to bore you by going through every single step of the algorithm. But this is just sort of my approach. So for depression, you can choose any of the antidepressants you want. Usually SSRIs, SNRIs, or bupropion. Brand name is Wellbutrin, or mirtazapine. Brand name is Remeron. Those are generally used. For GAD, usually recommended first line would be SSRIs or SNRIs. And if it's just anxiety, we can have Luke and Darth Vader battle it out on benzos versus non-benzo options. But if we look at that middle zone, thankfully we have a lot of options which can attack both. So thankfully, the most commonly used ones are SSRIs, SNRIs. Occasionally, we will add on things such as atypical antipsychotics, which can boost SSRI response. But as a general rule, those are the ones that we start with, and those are the ones that have the best safety data. So what I will do now is I'll just leave you with the slides. So this first slide is an algorithm for treating GAD in adults, not too different from what I was just discussing. Here are some things in terms of treating children. We use exactly the same meds. The only thing is we usually start at lower doses. There is a black box warning, the strongest warning the FDA has for anyone under the age of, I believe it's 24. About increased risk of suicidal thoughts and behaviors, so they need to be monitored closely. Thankfully, it's very, very rare, and there's talk of pulling that warning because more recent data are questioning it. And then here is a suggested algorithm for treating generalized anxiety in kids. In general, we start with SSRIs first. There's a lot more safety data for those in kids compared to SNRIs, but SNRIs are certainly down on the algorithm. So with that, I am going to turn it over to Dr. Welch. And my own exposure. So
let's see.
There we go.
Okay, I will reshare mine. So now all of you know what happens in every room Dr. Johnson leaves. Oops, sorry, I moved us way to the, every room that Dr. Johnson leaves, someone leans over and says, "Can he be my clinician?" Thank you so much knowledge and kindness. If you are gonna get a headache watching me scroll through the slides as fast as I can, I apologize. Just close your eyes and I'll tell you when I get there. All right, we're here. So in this last segment, before we move to questions, I want to talk a little bit with you about once we've got some goals, let's assume that's gone well. We may have a medicine on board. We know what the client sort of wants for their life, and or at least we're helping them get there. We've got some treatment goals. What now? So here's another idea that if I were with you in a room, I would be drawing this on a whiteboard. And if I'm in my office with a patient, I'm always using paper because I like to kind of draw things with them and them seeing it so that we can really think together. Doing it online is an interesting challenge. So I'm going to walk through this slide with you, but please know that part of the intention is really, again, to think about this common clinical dilemma with a bit of a frame that you can use really to individualize your treatment with the patient in a way that hopefully helps them stick it out with you and not get stuck or bogged down in the middle. So this third idea is to try to build a personalized treatment plan with each client, each patient, by categorizing their emotional reactions to each goal, where you're starting to look for, okay, we've got these big goals, now what's getting in the way? And this is where you can start to figure out, is it anxiety? Is it depression? Is it a mix of both? And that's what's going to really help you organize these treatments. Those of you who are trained in client-centered or patient-centered approaches, you are going to be really good at this. So let me talk to you a little bit what I mean. So if I were sitting with Adrian, the client that we talked about earlier, I might talk to them about the goals. And let's say we got these. A friend to talk to would be one goal, a few hobbies that I like, financial stability, and feeling comfortable in my own skin. These are the goals that Adrian is telling me would really make them feel like they have a life that isn't scary and depressing, isn't scary and sad. So then what I can start to do, if I'm thinking about using these particular technologies, behavior activation or exposure, I might start to ask Adrian, okay, so with a friend to talk to, let's talk a little bit about that goal. What gets in the way of that? And what Adrian told me, using that name, is it not their actual name, is that the thought of trying to talk to a friend actually makes them really anxious. And there's a whole lot to that where anxiety is getting in the way. And so as I'm hearing, okay, that's a really scary idea. I'm worried about not having social skills. I'm worried that no one will like me. I'm worried I don't look good. I've gained weight. There's all this kind of worry. And that's where it may need its own exposure hierarchy. So before I send Adrian out to kind of do an activation, or when I do, I'm going to expect that Adrian might need help with the anxiety around that. A few hobbies that I like. Adrian in this case said that they don't really know what they like to do anymore. It's been so long since life felt good that they're not really sure what hobbies they would like. But the idea of sampling, this is an idea I really like. I think I got it from a colleague of mine, Dr. Jennifer Dinenko. I think I stole this from her. She would always say, well, if you don't know what you like, that's okay. Just go ahead and sample. Try 7 things, and then you can report back. And you have to try them a couple times, and then we'll see if we can build what you like. But the activation target is sampling, doing something. And so here, Adrian's saying, I think I can do that. It's really about getting out of bed in the first place. And this is a more behavioral activation friendly kind of goal. So I'm sort of starting to be able to organize my treatment a little bit, my targets. Financial stability. This makes Adrian anxious and depressed to even think about. So that one's kind of big, and I've got both anxiety, I might have some depression there. And so that one isn't immediately obvious to me as the clinician, exactly what I do. So I might have to talk with Adrian a little bit more about that. I'm getting curious about uncertainty, but I'm not sure. And feeling comfortable in my own skin. Adrian, this client I'm drawing this example from, was actually kind of heartbreaking and said, I don't even know what that looks like, maybe looking better, but this is a goal that's not exactly formed yet. And again, that one, I'm not quite sure what my intervention is. It needs a little more assessment. So by using the goals in that frame, again, you can kind of see how then we're able to start thinking, okay, are we going after more of the depression, more of the anxiety? What intervention is going to help get us where we want to go the quickest? So that's the idea of this personalized plan. And I would absolutely, no matter what system you're in, and what, like we have a beautiful focus depression recovery manual, and it's got stuff for anxiety and depression in it. But you can still, like on the back of the page, draw this out for the client, help them organize it, because a lot of the treatment materials are sort of anxiety or depression. And part of our job with this co-occurring presentation is to help the client organize their way through. Okay, so once you have that, this might be, again, this, if I were doing it in practice, this would be really messy and it would be all over a piece of paper, most likely. But let me show you what this might look like. So for Adrienne, they might have a list of hobbies here, and we might see these little numbers, they're little ratings of, how difficult this might seem. Oh, book up a book. There's a mistake. I did not put that in on purpose, but nobody reassure me. There's a little exposure to not having perfect slides. Someone in the chat said learning, so that's good. So that Adrienne might look up a book on hobbies at the library. Try one thing. Try drawing. Now maybe Adrienne draws and it's awesome. Maybe Adrienne draws and starts to get worried that it doesn't look perfect enough, and then I need to help with the anxiety. We'll see as we get going. This is a process. It's not a linear one size fits all. It's very kind of iterative. Making something for dinner, taking a walk outside. This looks a little more classic BA, behavior activation. Over here, you can see the friends goal. Look at this list. Here we have more of a traditional anxiety hierarchy, where Adrienne isn't going to be able to just go do this. There's a lot of anxiety in the way, and we can help Adrienne by creating a hierarchy. I'm assuming a little knowledge of exposure in BA. So if this is super quick, also there's some really great training opportunities on these interventions, but I'm just gonna continue to go at a little bit of a rapid pace here, assuming some familiarity. Adrienne might text a coworker to say, hi, that might be a 2 on a 0 to 7 scale, let's say 7 being the highest anxiety. On up higher might be practicing small talk with someone at the grocery store. And these, in exposure, of course, we repeat these over and over again so that the brain can begin to learn something new, that it's not so bad, or that I can tolerate it, that I'm safer than I thought. Adrienne has a chance to learn if they actually have great social skills and it goes well, or if they need a little work, and then we can help there. So you can see how, again, this is somewhat of an organizational frame to help you really use these techniques. Talking in therapy about finances, just talking about it was actually quite scary and overwhelming for Adrienne. So I'm conceptualizing that as sort of an exposure, practicing tolerating the uncertainty of what's going to happen just in talking about it. So you can sort of see how we might start to organize, and this might morph and change over the course of treatment. Now, once you have this beautiful treatment plan, or maybe you have a client where it's really easy, like this is the BA, this is the anxiety exposure, you go for it. Just trust me when I tell you, no matter what, reorient to goals consistently. So, in our workbooks, if I'm using them, they're, a very long workbook with a ton of techniques. I want those goals written at the top of the page consistently. Why? Because I know that the best thing I can do for this client is to help them hang on to their goals with as tenaciously as they can, and try to help find a way, even in the hardest of situations. That is what the data is telling me is going to be the best thing I can do. Big picture. So once you have all these wonderful goals and alliance, you've got your common factors, you're starting a treatment plan, just keep going back to the goals. If your client gets stuck or forgets or demoralized, know that that's not your fault as a clinician. That is normal. That is the problem. And so you're typically going to have, if you have clients with these co-occurring conditions, they will probably need your help refocusing on that big picture until they start to get some traction and success. So really just remember, again, it seems kind of obvious, but it's a place I see in training and supervision. A lot of people in the kind of bogged down of the day-to-day and all the things that we're trying to do in the session, it can be easy to forget to just link what you're working on in the session, whatever that exposure goal is. Small talk with the cashier at the grocery store. Remember, this is part of what we're doing to help you get that life where you have a couple friends. That's why we're doing this again and again, again and again. Avoiding a disappointed or mildly punitive or overly clinical tone, avoid that at all costs with these patients. They are so sensitive to failing and so prone to kind of giving up and feeling like they can't do it. It's too much. So you really want, as the therapist, as the clinician, to model some of that persistence towards the goal no matter what, and really modeling an optimistic tone, not Pollyanna. We work with people whose lives are incredibly difficult, incredibly stressful. And if we could, we would take those stressors away from them. But we can't always do that. And so really modeling that optimistic tone, not that everything's sunny and rosy, but that you believe in them. That is the style, that is the tone that Dr. Johnson and I have found over and over again is the most helpful. Okay, thinking strategically, just real fast, and then we'll do a little, I think we're gonna do a few minutes of a role play so you can watch how we might try this. A great tip that I got that's helped me a lot is thinking strategically about sequencing. So if you can only work on a couple of things, or your client is overwhelmed and you can't really tackle the behavior activation and the exposure targets all at once, what do you do? So times when you might want to consider doing exposure first would be if there are real high value targets or goals where the client's likely to experience quick success. Like if they have a phobia, if that's part of their worry and they want to work on it, do it, because it's probably going to work really well and it's very motivating. Getting success is great. Often that's the best rapport builder. If the client's very motivated to work on a fear, that can be a great time to start with exposure. If the fear is what's preventing the client from engaging in other valued routines or activities, that can be a great time to start there or emphasize exposure first if you have to pick. Or when they become so anxious related to their behavior activation targets that they can't stick with them or have trouble getting traction, that's a good time to do exposure first. BA first. The client's so depressed that you have the sense, or they do, or you do together, that they won't have the energy to engage in exposure, it might be helpful to begin with just getting them some traction with their ADLs, getting some routines going. That could be a good move. If you think that the clients, this is a little thing I think about, if the client's relationships will be impaired by their lack of ADLs, I would always start first if they're not showering or grooming, because they're so down. It can really help them increase their social support just to get some of those basics down. It's just a little tip. If they're really motivated anywhere, start there. If their anxiety is more free form and kind of unlikely to interfere with their behavior activation targets, like the client that just says, I feel the sense that something's going to go badly, or I just sort of worry all the time, but I don't even know about what, that can be a place where you might have a little more traction early on with behavior activation because it's so clear and specific. And I might start there if I have the option. So just some ideas there. Last thing here is weaving behavior activation and exposure together if needed. So sometimes you might work on one or the other, or pick one target first and really lock in there. Other times you might have to weave a little bit back and forth. So for example, for the BA target, baking a friend, let's say the client has a lot of anxiety talking to people or making eye contact, small contact, then you might want to do exposure to those items, to those areas to help them get back to the BA. And you're sort of doing all of it together. You can just see on this slide other ways you might do that, like applying for jobs. Well, I don't know if I'm going to get it. What if I get rejected? There might be some exposure work in helping the client tolerate the uncertainty. Maybe I won't get anything, and I'm going to play anyway and tolerate that and practice that. You might use imaginal scripts or other techniques to do that. So these are just some examples. Going hiking, I put this on a slide. I thought of a client who really loved to hike, wasn't doing it, was depressed. Part of the barrier with hiking was a fear of being separated from parents. And what if something happened? And so there was some exposure to going without that phone all the time that helped engage the client with that BA target. Okay, let's show you what we might do. So we'll put ourselves on the spot a little bit and maybe just do a brief, we'll just do 5 minutes or so before the few last slides that we have before Q&A. And I'm going to be the therapist for my wonderful client, Brett, or Adrian. What is your name, lovely client?
I'm Adrian.
Adrian, okay. And Adrian and I have, because we've spent a little time on the overview, we're going to jump into, let's say we're a couple sessions in, and Adrian had some homework to work on some behavior activation, and I'm going to check in and see how it's going. So Adrian, we talked a lot last time about that behavior activation. How'd it go?
I did part of it, and so I'm worried that I'm going to let you down. And but I did some of it.
Oh, well, I'm so glad you did some of it, and I'm glad you told me that you're worried about letting me down too. There's I want you to know that my job is really to help you figure this out, and if you did part or you had trouble with it or whatever happened, that's what we're here to work on. We're a team. So I can't tell you don't worry, because of course that would violate what I told you before about how worry happens and it's normal. But I do want to let you know it's okay. Okay, so tell me what you did. Let's get into the nitty gritty a little bit.
Well, it was hard to leave the house, but I went out, and as you can tell, I have beautiful, lengthy, luscious locks of hair, and but my partner was getting mad because it was all over the place. So I went and got a haircut.
Oh my gosh, good! You did the haircut. Good.
Yeah. Yeah.
How did it go? How did you feel? What happened?
It took a while to get there, and I was sitting in the parking lot in the car for a while, and actually put the key back in the ignition to go home. But I remember sometimes you just said that I have to do the opposite of what my brain is telling me, and so I went in and I did it.
Fantastic. Oh, that is so wonderful. So that was an activation. It sounds like there was some anxiety that, and were you surprised by that? That wasn't something we had talked about too much, but it sounds like there was a lot of anxiety that you had to overcome in getting that haircut. What came up?
I just felt really stupid. Like, I used to get haircuts all the time. Normal people get haircuts. Like, I shouldn't have to work with a therapist on figuring out how to get a haircut, and just made me feel really hopeless. Like, if I can't even do this, and I'm worrying so much about a stupid haircut, like, how am I ever going to go out there? How am I going to, get back into work? If I can't do basic stuff, how is my partner not going to leave me? So, yeah, it just kind of spiraled from there.
Got it. Okay, thank you so much for telling me that. This is such a good example. This is perfect. First of all, you overcame a lot of fear and you did it. And that is huge. And that is part of what we know over time really does help people get from, this place where you are now, where everything feels hard. You're so worried about getting back to work and what's going to happen and your partner. And it's that, you hung on with both hands to that goal and you did it. And I'm really proud of you. I know it felt really, there was a lot of anxiety and sounds like some self-judgment and all kinds of stuff happened in doing it, which I want to talk a little bit about. That would be so perfect for what we're working on. But before we do that, did you get any positive reinforcement doing it, like after, or when, your partner saw it? Like, was there any of that little positive, or was it all kind of hard?
No, I mean, there definitely was some positive. When I parked my car and was walking into my apartment, someone actually looked at me and gave me a thumbs up. So
Oh, cool.
I don't know if that was a good thing, but they pointed to my head, so I hope it was a good thing. They weren't judging me. But when I got in, my partner said how nice it looked. So that felt good.
That felt good. Great. And did you get any of that? I don't know, sometimes doing something hard can feel you're just zonked and overwhelmed and tired. Sometimes it can feel really good. How'd that go for you? Just that you did it.
Yeah, at first I did feel a little bit proud because it was a goal that you and I had set. And then as I was sitting there and thinking about it, I kind of felt that it was kind of stupid to feel good because it's something that normal people do every day. So, but I tried to just hang on to the positive.
Yeah, no, this is okay. I'm like, no, yes, this is perfect because you did it. You got a little bit of that positive. Your hair looks fabulous. You're good. Your partner liked it, so that's great. And I think this can really illustrate for me, and us as a team, how some of those things that we're working on with your behavioral activation, there's a lot of emotion, of worry and judgment, and even, maybe some, I don't know if it's rumination or worry or both, but like, oh my God, if I can't do this thing, how am I going to go back to work? Normal people can do that. Like, those are the thoughts going through your mind. And of course, anybody having those thoughts, you're going to have a reaction to that. So it makes me think, Adrienne, that part of what we might want to do with our big goal of you being able to get back to work, I wonder if we might want to create a little hierarchy together. Think about what about the haircut actually triggered that anxiety.
Yeah.
If it were just haircuts and we were doing exposure, I think we've talked a little bit about that, where you pick something that gives you a lot of worry, but is with practice, you can get to where it's easier and you can overcome that fear and it feels better. Exposure works that way. It's like this new learning. If I could have you get haircuts 3 times a day, that might be a great exposure, but that might get kind of expensive. And then you wouldn't have all that beautiful hair.
Yeah.
But I wonder if we could actually figure out together today what some other things that might kind of cue up or trigger that same feeling that you had of like what the anxiety is, what feels scary or hard. Like maybe it's other social situations or going out. Like, are there other things you can think of that would create that same feeling? Like with the haircut, like where you're maybe the center of attention, or I don't know, I'm thinking about what the anxiety is about there.
Yeah. Grocery shopping. I haven't.
Yeah. Okay.
In about a year. So my partner does all that, and they get kind of annoyed with me, as I would, being lazy and not doing anything, right?
The anxiety, tell me what the anxiety is that's similar to getting the haircut, because that sounds like what's kind of getting in the way of you doing it.
Just that I'm broken, that something's wrong, that I'm never going to get back on track, that keep circling back to losing my partner or not getting a job. And, so.
Got it. So for you to feel better about those, it sounds like let me run this by you, and then maybe if we've got this frame right, kind of the goal, we might be able to do a kind of a cool little exposure hierarchy, that you could go out and do things. Think if we could figure out what's making you anxious there, we might be able to set up a little hierarchy to help you repeat it.
Yeah.
Okay, so that would be the start of us. Probably my next step would be to figure out what's making Adrienne anxious. I have some hypotheses about being the center of attention or interacting with others in public, and we might build a hierarchy there. I'm going to just end before the Q&A with a study to go look up. It's on COVID coping, what helps people during the pandemic. Really cool Canadian study. It's approach, guys, this goal persistence, approaching goals. And of all the things you could think about that positive frame, again, same themes emerge. And I just wanted to end with a nod towards other colleagues who are doing work that's similar to what we described in this talk. Some of you may know or be curious about the Unified Protocol. Dave Barlow and colleagues are really doing a lot with these co-occurring disorders. Modular treatment frames such as Bruce Torpeda, John Weiss's are other examples of some of these ideas that people are out there studying, and it's a real contribution to the literature. So thank you all so much. I'm going to turn it over to you, Michelle.
Well, thank you, Dr. Welch and Dr. Johnson. I'm seeing in the chat that everyone really enjoyed the role play and the outcomes and how it puts everything together. Now it's time to answer questions. Just a reminder, if you do have a question, please use the Q&A button, not the chat feature, on the Zoom taskbar. We will try to answer as many as we can in the time we have left. If we don't get to your question, please send me an email message afterwards and I'll follow up with you. Okay, it looks like the first question is, I have found it hard to get my adolescent clients started with goals and values. I have tried to ask my clients, what do you not want? And they are able to identify this, but then still get stuck on developing clear goals and values to work towards. Do you have any other tips on how to manage clients like this?
I'll say one thing that comes to mind, and then please jump in, Dr. J. But with adolescents, it's such a cool question. I really love this question because with adolescents, if you think about it developmentally, they're developing their identity. That's part of their big job, is to figure out what their goals are, what their life is about. So I really take that in stride. And what I will typically do is share that with my clients, just say, cool, you don't know what you're about. That's exactly where you're supposed to be. I love, as I said before, this sampling idea. Let's try some things out. If they know what they don't want and they're not clear what they do want, I like to just have them even try out some different ways of living. They don't have to commit to anything, but that's probably the closest I can get to trying to get them on this trajectory that really is normative, where as a teenager, you're kind of trying different things out and seeing what fits. So that's an initial take.
Yeah, I would just echo everything that you said, Dr. Welch. I think it has to be done carefully. I tend to be somewhat silly and a jokester, but I don't know about your experience. Maybe everyone in Seattle is, all the adolescents are thrilled to come into treatment, but a lot of the young people that we see here, there is definitely some ambivalence, about being here, and what's the point? And I'm missing out in school and sports and blah, blah, blah. So I think oftentimes just, going back and sort of processing the ambivalence and sort of like what they're missing out on temporarily compared to, if they do get this under control, not fixed, but under control and manageable, it will enable them to go. But the first couple of sessions can be a little surly and rough sometimes.
Thank you so much. Our next question is also about kids and adolescents. I work with kids and adolescents. Do you have any suggestions on how parents can get involved and best support their kids who present with MDD and GAD? Parents tend to get confused when trying to understand providing their kids support versus providing their kids unhelpful accommodation.
Mm-hmm. Yeah. I can start off and then I'll turn it over to Dr. Welch. So it's a fantastic question, whoever asked that. And one of the things that I really love about Rogers is, and it's a total luxury that is not available. I've worked in community mental health settings. I absolutely realize that it's not available all the time. And yet we take a very family-centered approach, even though obviously, we have the patient who's in treatment. And I don't mean this in a disparaging way, but one thing that Rogers does not do is what I call the Jiffy Lube approach, dropping off your child, expecting them to be fixed, whatever that means, and then picking them up. So parent involvement is absolutely key. And I think seeing kids and adolescents, and I would actually extend that to a young adults or some young adults who have had challenges, progressing through the developmental milestones, or with COVID. Wow, the number of people who have no choice and they have to come back and be with family. So I think what I found helpful is trying to get them to have because oftentimes they feel that if they set limits and boundaries that they're going to be harsh, right? But like Dr. Welch was saying, like in the therapeutic relationship, different, of course, that you do want to be positive and upbeat. And at the same point, we have to make sure that family accommodation is also addressed. But it can be a very delicate and nuanced dance. And I'm sure Dr. Welch is going to have a better answer for that in her vast therapy knowledge.
So much better. No, just kidding. I think that I agree with all of that. The other thing I think about with accommodation, I find this as a parent myself, we're so wanting and kind of wired to help our kids when they're distressed.
Yes.
And a lot of times the same parents who are so skilled at helping their kids regulate emotions almost overdo it, where the kid who's like, I'm really depressed, I want to stay home. Someone takes the day off work and watches movies all day with them, they're going to feel better for that day, but long term it's not so helpful because they actually need to learn more to overcome that mood state. Right. So I find a lot of my conversations with parents are about thinking through with them what the goal is there, even for their parenting. What while your child is under your roof, what do you most want to help them learn, to help them succeed in their lives? And sort of thinking about these big picture frames I find is really helpful to helping parents reduce the amount of accommodation. We know more about that with anxiety disorders than with depression, but it tends to be really important. I think also just having kind of some real talk with parents. Sometimes they almost have to be kind of like the heavy, and we can try to do that too as clinicians, but sometimes kids need that have to, and it's really hard to do that as a parent, but really bringing them in so they're the expert along with you and the child, and part of that process, as you said, Dr. Johnson, I think is just essential. I guess, and just validating how hard it is. It's really hard. It's really hard.
Totally.
Thank you. We have a lot of questions as it regards to treating patients on the spectrum. And this one seems to wrap it up a bit. Would you recommend utilizing these behavioral interventions for individuals who maybe also be diagnosed with high functioning ASD? Are there modifications that you may suggest?
Off the top of my head, a couple things that I'd say, and then jump in, Dr. J. But I think the behavioral activation certainly, and I think that concrete, routine and doing things can be really cool. With kids on the spectrum, often making things very concrete,
Yes.
making them visual, including support team, caregivers, family members can be really, really helpful. Making sure that there are clear rewards along the way can really help. It's kind of things that we would do anyway, but can be particularly important for kids on the spectrum. The uncertainty frame, I think, is sometimes more challenging. So that would be one. I might sequence that later or make that. That would be the one I'd probably be the most tentative about, just because the concepts are pretty abstract and can be a little bit more challenging. But tolerating anxiety in the service of moving towards goals, however that looks, absolutely. Anything you'd add to that, Dr. Johnson?
No, I think that is an excellent point, and maybe it's my pathologically strength-based nature. But I just to circle back what you said, I think we often have to look at the challenges of people who maybe on the spectrum or versus neurotypical. But I think that there are opportunities as well. I've had patients who do have some of the rigidity frequently seen in ASD, and they will follow things to a T. They will follow that list and they will bring it in. Now, I think one thing that that I've that I've made the mistake of is that sometimes things may be taken very literally. I tend to use my style is a lot of metaphors, examples, and those things. So sometimes I find I have to dial those back and make them a little bit more concrete and practical. But I actually look at it as somewhat as an opportunity as well, honestly.
And there's a webinar, I think next month, actually, some of our colleagues are at Rogers are doing a webinar, I believe. Drs. Franklin and Nadeau, is that right, Michelle?
Yes. And they're so, and I just saw a suggestion that we do more on ASD, so that's wonderful. And there are just so many great questions here, but that's all the time we have for today. So again, shoot me an email if your question did not get answered. I tried to wrap them in the best I could, but many thanks to our presenters, Dr. Welch and Dr. Johnson, for taking the time away from your clinical practice to share your valuable insights with us. Helping a patient to the road to recovery means collaboration among everyone involved in their treatment. With locations across the country, our treatment teams are ready to partner with you. Rogers outreach representatives are happy to answer questions regarding our treatment services, as well as learn more about your practice. Before we conclude, I'd like to ask our presenters to share a few additional resources on this topic with our participants.
Yes, two great organizations to follow up with are the Anxiety and Depression Association of America, and their website is there, and the Association for Behavioral and Cognitive Therapies, which have a lot of information about the topics we discussed today.
Thank you. That about wraps it up, everyone. I just want to remind our participants that those of you who met the required time commitment will be eligible for CE credits. About 30 minutes after the webinar ends, you will receive an email with a link to your personal dashboard on ce-go.com, where you will be able to access PDFs of the PowerPoint presentation slide handout and a complete list of references. Those of you who met the time requirement to qualify for CE credits will need to complete the evaluation to download your CE certificate for the event. If you have any questions about this follow-up email, please contact support at ce-go.com. On behalf of everyone at Rogers, we look forward to partnering with you to help support your patients. Thank you.
Thanks for joining us.
Thank you.